So today the task assigned to me is to talk about IR and its role in the management of advanced HCC. So I'd like to get my slides on, and I think you all should be able to see it now. So effectively, let me start by an algorithm which has been done to death virtually, and we all really know it, and we probably can even write out this in our sleep. And advanced HCC is effectively when portal vein invasion happens, and with the deteriorating performance status, these so-called standards at the moment still talk of SIRveNIB. And probably SIRveNIB is the prescribed medication by which all standards and newer therapies are then to be judged and seen how they figure to find their place in the algorithm. So interestingly, going back to some of the data that we looked up, and this was a publication that came out in 2019, it talked about SIRT and SIRT plus SIRveNIB in one of the studies and how it fared against controls. So if you look at the studies where SIRT versus control happened, you would see a median survival of 16 months versus 8 months in the control group. And if you look at SIRT versus SIRveNIB, there was a median survival of 26 months, which is nearly 4 times that of the group who had been given only SIRveNIB alone. These were case control studies, and therefore an observational in design. So therefore it made sense to really quickly plunge into a randomized trial to really place SIRveNIB in the perspective of advanced liver cancer. So in 2017, the SIRveNIB trial started, and then when it was completed, this was a study that happened in Europe, and simultaneously the SARA trial started in Asia, and this was reported again in 2018. And would you believe it, in both the randomized studies, SIRT seemed to be distinctly not just equal, but it was inferior. We had something like 8 months versus 10 and 11 months survival, overall survival, which was actually the primary endpoint for both of these studies. And it came as a huge surprise. And this really shook up everybody's confidence in SIRT. And therefore, it's imperative that we understand these trials and see what messages we are getting from them. And we'll go into these in a little while. But effectively, before, in day-to-day practice, how do we look at patients of unresectable HCC, especially when we want to offer SIRT? We must understand that we must select the right patients. And this data was very useful to really decide in routine practice that if the extent of replacement of hepatic parenchyma is more than 60 to 70%, then your patient might not just be the best person to do Y90 on. And so if the patient has had previous cycles of chemotherapy, child's Pew status distinctly tells us that a child's A would be better and much better than child's B or C, and B7 is virtually now the cutoff figure, and we'll come to that also later on. Obviously, the patients who will do well will be the patients who would show radiological response to treatment. There's no doubting that. And bilirubin as a single factor, if it is less than 1.9 apparently, would definitely help you in triaging patients and offering patients SIRT. So in 2015, about 1,500 patients were evaluated, and they looked at 8 studies. Again, these were not randomized studies. And it started showing that as compared to TACE, in the setting of advanced HCC, it showed that there was definitely an overall survival tilting in favor of Y90. And this survival actually widened as the years went by. So if you look at 3-year overall survival, the difference was even higher. So the first and second years, it was not so much, but 3 years was significantly more. And it correlated very well with the prolonged TTP, and the time to tumor progression was definitely far more in Y90, with the associated reduction in the hospital time days, which helped the patient spend lesser time in the hospital. And being a very patient friendly and tolerant procedure, the complication rates were distinctly very, very less. Now, here's another slide which I really wanted to share with everybody, just highlighting again what we just discussed, that the impact of the child score and the impact of the portal vein thrombosis and the extent of the portal vein thrombosis really determines outcome. If we look at a child's A patient, and if we look at a patient who has only branch PVT, you would expect a nearly 16-month survival, but it would dramatically fall even if he were to stay in child's A. But if the thrombus has extended to the main portal vein, it would come down to 7.7 months. Similarly, if you look at child's B, now child's B with only branch PVT is only 6.5 months survival. So look how 16.6 falls to 6.5 if the child score changes from A to B. And similarly, in child's B, you would see that the results of branch PVT and main PVT are even worse than in child's A. So all of these factors come into play, the extent of the PBTT as well as of the child score, that really determines outcome. And that's what we should really use when we do an OPD consultation and actually optimally select patients and prognosticate for them the outcomes of treatments. So let's get back now to those two studies that I was talking about. The SARA study was the Asian study in which all eligible patients were advanced HCC who had failed at least 2 sessions of TACE, or they were inoperable HCCs, and the child score was, like I mentioned, less than B7 with a reasonably good performance status. They were randomized to SIRveNIB and to SIRveNIB, and about nearly equal numbers were randomized to both groups, and overall survival was what was looked at as the primary endpoint. The average activity given to a patient per treatment session was 0.95 GBQ, and the average activity per patient was 1.39 GBQ, in the sense that if the patient needed bilobar treatments, it was done in 2 sessions. SIRveNIB was given at a dose of 800 milligrams. That's 400 twice a day. Now, if we look at the intention to treat population, that means the entire 2 groups, this is what we saw. We saw that SIRT was actually showing only an 8-month survival, whereas SIRveNIB was showing 9.9 months. But we realized that actually 26%, a quarter of the patient randomized to SIRT, did not receive the SIRT. Yet since it was an ITT group, it had to be extrapolated, and the data were analyzed in both groups, inclusive of all the patients, whether they received SIRT or not, once they were randomized to the SIRT arm. And SIRT obviously would then do worse, and I'm not surprised. So therefore, if we look at this, we find that 52 patients from the SIRT group actually did not receive SIRT, whereas only 10 patients fell out of the SIRveNIB arm when the therapy was initiated. The other interesting thing is that, that SIRT for some reason was given 1 month after the randomization happened, and we're not quite sure why that happened, whereas SIRveNIB took off within 3 to 9 days of this randomization. So this delay in randomization is also a factor which we don't really understand why this happened. And if you look at the treated population, therefore, you find that they are virtually equal again. So it's, if you exclude the group that did not receive SIRT. But if you're looking at the adverse events, there's no doubting it that the adverse events were distinctly more in the SIRveNIB group, and severe were also much more in the SIRveNIB group. And that's just highlighted in this. You can move on further. The quality of life was correspondingly, therefore, definitely superior in the SIRT arm as compared to the sorafenib arm. So therefore, we can say at best that it was similar to sorafenib, better tolerated, lesser side effects, and better quality of life is what we could see. Now, the most important thing that came out of this was that if you look at the correlation with dosage, now over time we've come to understand that you've got to give 100 to 120 gray to the tumor. So from the same patient population, if we looked at patients who had received more than 100 gray, the survival was 14.1 months, whereas it was less than around 6 months if they were given less than 100 gray. And now we don't have really information as to why there is so much variation. Why were patients given differing amounts of radiation to their tumors? If you look at the disease control was significantly more in patients who received 120 gray or more compared to patients who received lesser amount of radiation. The other important point was that your therapy has to match what you had planned. And if the therapy sat the way the planning happened, the overall survival was actually 24.9 months. So apparently in a large number of patients, we don't know how the therapy was done and why the therapy did not sit the way it was intended to sit as per the MAA study that is part of the part 1 workup. So there are a lot of fallacies and things that are critical of the SARA trial. And so I would really look at this data and say that if you do the SIRT right, you give the right dosage, you do the appropriate targeting, we should see survival of about 24 months. And it should not be as bad as the 9 months that the overall analysis has portrayed. And similar things go in the SIRveNIB trial, which actually came from the West. And again, it was structured in the same manner in which sorafenib and SIRSphere were used after randomization in patients with portal vein thrombosis, and they looked at survival. Again, the same problem that it happened 3 weeks or more afterwards, after the randomization, the SIRT took off, and the mean dose again was given was 1.8 GBQ. We don't understand here now how many grays were really delivered. We just have the GBQ data here. And again, we understand that the randomization here was 21 days, and again, nearly a third of patients did not receive SIRT. And I'm not surprised that both, therefore, pictures of SIRveNIB and SARA seem to match very closely. And we again find that the data is very similar. When you look at treated populations, SIRT seems to be marginally superior to sorafenib. And if you look at the time to tumor progression, SIRT is slightly marginally better. And if you look at the tumor response rates, yes, definitely SIRT is controlling tumor much better than sorafenib is. And the adverse events are distinctly lesser. And again, giving similar comments again on the SIRveNIB, that we have overall survival is comparable and progression-free survival is better, tumor response rates are better, and adverse events are better. So if we can really spend just a few seconds on this algorithm, therefore, in the advanced stage, if we appropriately select our patients like I've been trying to emphasize, then I think with liver dominant, low bilirubin, Child's A or B7, and do the SIRT right, I think it should find its place here in the therapy strategies for advanced HCC. And that's how it's come in as recommendations from Apple, in which they've said that with level B1 evidence, it may be used as first-line therapy in advanced HCC with portal vein thrombosis. It can be used as first-line therapy in multifocal or bilobar HCC with high disease burden. If TACE is failing, definitely it should figure as second-line therapy. It should be used as bridging therapy for transplantation because it has very good power to hold the tumor at bay, and then downstaging definitely before surgery, be it resection and transplant. Of course, Prashant will talk about. NCCN also talks about it in a similar manner. I won't go into the details of this. Just wanted to share just a couple of slides, but Prashant will actually talk about downstaging HCC to transplant, just a data to just put it in perspective. There is interesting data to say that Y90 scores in all methods superior to TACE when it comes to downstaging HCC for transplantation, be it event-free survival and overall survival. censored or uncensored, would be superior in the TARE arm as compared to the DACE arms. And if you look at this over 1 year, 2 years, and 3 years, the difference becomes more and more marked, and TARE shows its superiority in longevity of 45% versus 19% if it is censored to radical therapies or uncensored, both ways. TARE seems to be better if you were to incorporate that in the strategy rather than using TACE. And I think it's definitely better than SIRveNIB. Again, it says that, again, if you look at the 3 years, you would see that the difference shows up and becomes more marked. And of course, whoever would go to transplant would go down the TARE arm rather than SIRveNIB alone. Just to show you one last case, this is a tumor here, you can see, and the tumor from the segment 4 is extended into the left main portal vein, gone all the way down there into the left portal vein. The thrombus is distinctly seen, bulging and pouting and enhancing in the portal vein. So there's no doubt that this is a portal vein tumor thrombus. This patient was given Y90, and after Y90, you can see the tumor kill there, and the portal vein opens out. The tumor thrombus is nicely retracted back. And just to show you the reference, the below picture is how it was, and that's how it is now. And you can see that the left portal vein, which was so heavily burdened with portal vein thrombus, has really opened out as the thrombus got retracted and it fell out, recanalizing the portal vein there. And then this patient went on to transplant. So I would just close here and thank you very much, trying to put the use of SIRT in perspective in advanced HCC. Thanks.
Thank you, Dr. Baijal, for that fantastic overview and the critique of those two studies. There are a couple of questions from the floor, which I think the first one comes from Bharat Gupta.
Right.
The question is, should MAA distribution always be taken as a surrogate marker for Y90 distribution?
Right.
And should extrahepatic disease be taken as a contraindication for Y90?
So I think it's a very sensible point that the MAA has to sit, and it's purely based on MAA that we really plan the entire therapy. And the dosimetry has changed dramatically. We've done away with the body surface area and gone into the partition model. And for the partition model, it's extremely important that the MAA be used for planning your dose calculations, and hence it is absolutely important that you have to get your MAA sitting the way you want it, and you've got to do the arterial redistribution strategies in your part 1 of the Y90 treatments protocol to ensure that your MAA sits optimally and you get very good tumor to normal ratios. And then the MAA would actually also give you the safety profile, because you'll be able to calculate the liver lung shunt and keep your lungs from getting burnt up, and also protect any inadvertent aberrant embolization and sending of particles into the gut where you would have some ulcerations. The second point was extrahepatic disease. Now that's a difficult one, and it's a moot point for debate, and I don't think there is a clear-cut answer to it. It's been left very ambiguous in most of the recommendations, and it says that limited extrahepatic disease should not be considered as a contraindication for Y90. That's about the only thing I can say on that, because limited extrahepatic disease is a very subjective thing to really base your decision on. So I don't have a clear-cut absolute yes or no to that. But I would say that small burden of disease, I think we should definitely go ahead and still do Y90.
Sure. I mean, I think, is it fair to say that if liver is actually the life-limiting disease, then TARE would be a better option than elsewhere? So would that be sort of a...
I think so. I guess so. But then I think that's just about it.
Sure.
And then with that, we would definitely have to add systemic therapies along with it if we have extrahepatic disease as well.
Sure.
I think we have another question which says the experience on poorly differentiated HCC. Do we have to do a PET CT before planning for Y90? We haven't really used that, but we've come to realize that tumors that are infiltrative in nature are usually poorly differentiated, and the ones that are more PET avid are the ones which are biologically more angry tumors, and these would be patients who would probably not perform as well as would the other patients with well circumscribed and localized HCC. But to say that we would not offer this therapy, I think these are the patients who really need more of aggression, at least local aggression, especially if it is liver centered disease, to give them a chance to really hold the disease at bay or pull them backwards to get them to the surgeons for some kind of hope to cure. So I would say that we don't do a PET CT. Absolutely, it's not a must for planning, but we certainly do at least a CT of the chest, so that we should know if there is disease burden beyond the abdomen. Is there a role of repeat tear is another question. I think yes, there is. We have now in our experience a group of patients who've had more than one tear session, and the natural follow-up question would be, how do you decide when to do a repeat tear? So we've seen that delayed tumor response can go even up to 3 months and 6 months. So we look at disease. I'll just put the phone on silent. If there is stable disease and continuous tumor response as per imaging criteria, we would not repeat the Y90, and we would repeat the Y90 if there is a progress of the tumor after showing a good response at least 6 months later. But if we see an early failure at 3 months, I'm not so sure I would be very keen on considering a repeat Y90.